Hello, everyone. Today I have Dr. Jonathan Nassos, who is an orthopedic sports medicine doctor in Southern California. How are you doing, Dr. Nassos?
Doing well, thank you. How are you?
I'm doing pretty good. So, the first question is what really inspired you to go into orthopedics?
Well, initially it was I was inspired to go into medicine and mainly it's to help people. Essentially, that's kind of the most basic reason. Um, I was exposed to it due to my father being a physician, and so I was around the hospital as a child growing up here and there. Um, and specifically orthopedics. I think I was drawn to it after um, sustaining some injuries where I needed surgery myself, uh,
Mhm.
as well as growing up playing sports and having other minor injuries here and there, and knowing that sports medicine was able to get me back on the field again.
Yeah. So, was that the reason why you picked sports medicine over something different like hand or spine or joint replacement or something?
I would say it was mostly my exposure. It's really sports medicine that drew me to orthopedics in general. Obviously, orthopedics has a number of different subspecialties like hand, spine, foot and ankle, joint replacement, but it was sports medicine that drew me um, to the specialty. Uh, and while I do like other areas, um, other subspecialty areas of orthopedics, I think I enjoy taking care of the sports medicine population the most. You treat them, potentially operate on them, and for the most part, they get better and they're on their way.
Yeah.
It's not always the case in some of the other subspecialties, unfortunately.
Yeah. And what's the difference between someone like you, who's an orthopedic sports medicine doctor, versus some other specialty that goes into sports medicine, like family medicine or PMNR or something like that?
Sure, there's primary care sports medicine. So any primary care physician can get additional or go through additional training in sports medicine, and they will treat all the same sports injuries that we do as orthopedic surgeons and orthopedic surgery sports medicine specialists, including injections and all other non-operative care. But once there's a surgical lesion that can be corrected, then uh, that is where our specialty comes into play. So obviously, they're not able to perform surgery if they didn't go through that type of training.
All right. And what was your journey to becoming a physician like? Did you always know that you were going to be pre-med, or did it kind of change halfway through? What was it? What was it like?
I would say probably in high school, I was starting to lean towards medicine in general, not necessarily orthopedic surgery at that young of an age, but in medicine, leaning towards medicine in general. And so I did declare a pre-med. Well, I participated in the pre-med curriculum when I went into college, even though it wasn't necessarily a major. I majored in economics to uh, hopefully give me a business background, which I believe it did to some degree. And then following the pre-med curriculum in college, you go through 4 years of medical school. From there, it was 5 years of residency, and then any fellowship that you do, which is additional optional training in a subspecialty of orthopedic surgery, is 1 year. So I chose sports medicine as my subspecialty and did a 1 year fellowship.
Do you have any interesting stories from medical school or residency, or something that puts a smile on your face, or kind of, you know, evokes an emotion of some kind?
Um, during my fellowship, I had the opportunity to take care of or assist in the care of professional athletes, including the athletes of the Dodgers, Los Angeles Lakers, Anaheim Ducks at the time, Los Angeles Kings. And that year, as a fellow, we would rotate covering the games, whether it's a Dodgers game, Lakers game, Kings game. And the Lakers were playing the Celtics in the NBA championship series. And so they went to 7 games, and there were 8 fellows, and it was just a random kind of luck of the draw that I was able to cover Game 7 at Staples Center. So when they won the NBA championship over the Boston Celtics, I was able to participate in the celebration in the locker room, get a picture with the Larry O'Brien trophy. And it was special. I have memories of, Kobe Bryant, bless his soul, from that year, and taking care of him and the other athletes. So I'd say those are the most memorable events, especially of my fellowship here.
That sounds so cool. That's awesome. How would someone who is interested in being a team, like a physician for a sports team, how would they go about that?
Well, you certainly need to go through medical school and residency, and then you should specialize in sports medicine. So as we mentioned before, it can be primary care sports medicine if you don't go through the orthopedic surgery route, or orthopedic surgery sports medicine. So that's the first step, is getting all that training. And then part of the training that you get, notably in fellowship, usually they're affiliated with teams, and so you'll get that exposure.
Okay.
You can, how else can you become a team physician? I mean, you can offer your services at high schools, local high schools. But as far as the professional teams, it's a little bit more complex in becoming a team physician, which I would say I am not any longer a team physician for them. But during my fellowship, I was an assistant team physician and assisted in the medical care of those athletes.
Yeah, that's still awesome. Like not many people can say that they treated some professional athletes like right after a game or during a game. That's awesome.
No, it was definitely a memorable year during my fellowship.
Mm-hmm. What is your favorite part of your job?
I would say when the patients return after treatment and they're improved, and they tell me that, hey, my pain's better, I can walk better now, I'm able to go back to work and provide for my family, or I'm able to get back on the tennis court because of the treatment that's been rendered by me in my office. And so that's the most rewarding part of being a physician.
Yeah. I know there's some specialties where the patients will come into the clinic and the physician or provider will give them advice and they just will ignore it. And then they'll come back and they'll wonder why they haven't gotten better, even though they haven't taken any actionable steps to do so. How do you deal with somebody like that?
I would tell them that we have treatment guidelines for your problem, and we're recommending this treatment to get you better. And the only way that this is going to happen is if you follow the treatment guidelines. And if you are not compliant with that, then there's no purpose for you returning to the office. So I don't know what you're seeking, but maybe go somewhere else to seek whatever you are. But if you truly have an orthopedic problem and you want to get better, then you need to be compliant with the treatment recommendations.
Yeah. Would you say that like the athletes that you treat are usually very good about staying on top of their rehab? And
I would say that the athletes are compliant. Yes. I don't have too many problems with patients not following treatment recommendations. If there are issues, it's typically due to a work schedule, family obligations where they can't go to their physical therapy. People lead busy lives. Some people are torn in multiple different directions between their professional career or their family or any other duties they may have. So, that would be the explanation of anyone that comes into my office that may not be compliant, and I'm understanding of that.
Yeah, that's really, really nice, because I know there's some specialties or some physicians, their patients just don't like, they come into the office expecting to get better in the one visit, and it just doesn't happen like that. So
I would
that's
say
really,
part of that is setting realistic expectations as well with your patient. So if you set the expectations, typically the treatment course and recovery is much better. So they know, and they realize that, okay, they're not going to get better in 1 week. Let's say 2 sessions of physical therapy is not going to miraculously cure your shoulder pain. You need to do a course of it. And so counseling the patients and giving those expectations, I think, helps with ultimately their outcome.
yeah. What would you say is some of the most challenging things that you see on a daily basis?
Are you specifically referring to a condition or just the type of patient?
Whatever,
Whatever.
maybe both.
There are some patients that have all kinds of other issues besides an orthopedic problem. For instance, in workers' compensation, someone gets injured on the job, and let's say they injure their wrist, and they develop a dorsal ganglion cyst, so like a mass in the back of the wrist. But psychologically, they feel that, for me, I have this pain in my this is my employer's fault, or they may have other issues going on in their life. And so, I can tell these patients, hey, you got a cyst there, you're complaining of wrist pain. I can excise that as a surgeon, but it's not going to make your job better or you like your job more. It's not going to fix maybe the marital issues that you're having right now.
Mm-hmm.
Okay. And so all these things can contribute to the perception of pain in patients. And so it can be frustrating at times where you believe you know the diagnosis and the proper treatment, and you treat them, and maybe they get a little bit better, but there's still ongoing complaints. And you have to accept as a physician that sometimes you are not going to completely cure a patient and rid them of all their orthopedic complaints in my situation. So coming to that realization as a physician is important. Otherwise you'll be stressed and depressed, seeing patients here and there that just you can't help, at least on an orthopedic basis.
Do you think that a lot of people who have orthopedic issues, their condition is like exacerbated by some other factor that isn't the orthopedic issue itself? Like you said, that they're having other stresses in their life.
I think that I certainly think that contributes to it. Even clinical diagnosis of depression will certainly magnify a lot of these complaints. And many patients come in with that concomitant diagnosis of depression, along with their knee arthritis or their rotator cuff tear. So absolutely, there are other factors besides just the structural abnormality that you might see on an MRI that are contributing to their condition and their complaints.
Yeah. And do you normally like refer them to a psychologist or a psychiatrist if you really think that their orthopedic complaint is secondary to their life situation or stress in their life?
I will if I determine that that is an issue. I will ask them. I won't just refer them, but I'll have that discussion with them. Hey, are you feeling anxious about your situation? Are you depressed? Are you, and if they say yes, and I said, would you like to speak with someone about that? I'm happy to refer them to a psychologist or psychiatrist for help in that area.
Yeah.
Yeah.
Do you have a patient that you took care of in any point of your career that you just will not forget?
Um, trying to, there is one that was she was rewarding because she was hit by a bus, and so she had multiple injuries, and then I had to do multiple surgeries on her, and she did rather well, and she was pretty debilitated when she first presented to the office. So yeah, I still remember her. Last time I probably saw her was like 9 years ago, and I still remember her name, and what happened to her and what I did as far as treatment. So that was one. And then as a physician, there are always, you can have a complication that's out of your control, especially post-operatively. And so there's a patient from a while back that I still remember that had a post-operative complication, but sticking with that patient and not abandoning them, and walking them through that complication is very important for a physician. And thankfully he did extremely well in the end. But something like that is very stressful for me. It's obviously very stressful for the patient, but ultimately that worked out well.
Yeah. A lot of things that people don't think about when they're choosing a specialty or just in general is the outcome of the patient, because they'll just think like that neurosurgery, right? They'll think, oh my God, I get to cut into people's heads. It's so cool. But then realistically, the outcomes are not super great. Like they're obviously getting better and better. But if you're a neurosurgeon, you will have a lot of patients that just will either be debilitated the rest of their life or they just won't make it. So how much of a factor was the outcomes of your patients when picking your specialty or continuing with your specialty in your fellowship, something like that?
I would say within my specialty of orthopedics, I I believe that certainly played a role. It was a factor in deciding on sports medicine because I don't know if this is necessarily the best or I should say accurate advice, but I remember a mentor saying, for spine surgery, which I do like spine surgery. It's very. I remember I was amazed being able to operate on the spine as a resident when I was training. But he said you need to be okay with possibly paralyzing a patient if you're a spine surgeon, and because that could definitely happen throughout your career. Complications happen, and I said to myself, I don't know if I want to. I don't know if I want to be in that position. But when you're a surgeon, the moment you take a scalpel to the skin, there's potential for complications, all kinds of complications. But I would say in sports medicine, they're usually healthier patients that you're operating on, lower complication risks. So that certainly played a part in choosing that subspecialty.
Yeah. Did you ever have a patient that had an intraoperative complication? And if so, how did you deal with that, like mentally? That must be incredibly difficult.
Sure, that certainly can happen and has happened, and it is stressful, but you prepare for possible complications before you walk into the operating room. So you have to make sure that if you're doing, let's say, a knee replacement, you could potentially fracture part of the femoral condyle. So you need to make sure that you have the appropriate equipment, including fluoroscopy and fracture trays or trauma trays to fix that and complete the procedure. So I think being prepared before you even start the procedure for the potential complications, I think would sets my mind at ease much more than if you're unprepared. Then the stress goes through the roof.
Yeah, that's also why like research before doing a procedure, if like a procedure that you haven't necessarily been super practiced in, is very, very important, because
Sure.
everything, like things can go wrong no matter what. So always being
Absolutely. If you're a surgeon, you've been in practice long enough, you've had complications. It's just the nature of being a surgeon. Just I can't say I wouldn't believe anyone that said they're in practice say for like 20 years and say like I've never had a complication. I just wouldn't buy that.
Yeah.
It's the human body. It's the human body, and we can't control everything. Even if we attempt to minimize the risks as much as possible, it can still happen.
Yeah. What are some of the most common procedures that you do, either in the operating room or in the office?
In the office, the only procedures that I do are mainly injections, and that can include cortisone injections, platelet-rich plasma injections, that's a biologic injection, or viscosupplementation, which is hyaluronic acid injections, and we typically will use that for osteoarthritis of a joint. In the OR, I most commonly operate on the shoulder and the knee, I would say. And the shoulder, the most common operation would be a shoulder arthroscopy, which is making small incisions, putting the camera inside the joint, and doing a procedure in that minimally invasive fashion. I do a number of rotator cuff tendon repairs for the knee. I'll do simple arthroscopy, which again, using small incisions, putting a camera in the joint, and then fixing the problem, whether it's doing a meniscus debridement or cartilage debridement or repair, doing a ligament reconstruction, or I do knee replacement as well. So I replace the entire joint. So those are the most common procedures. I do some straightforward hand procedures, elbow and hip. But I do not operate in the spine. If someone needs spine surgery, I send them to the spine specialist.
Yeah. Do you use any robotics, any new, like, I guess the word is cutting edge techniques in your operating room?
I do. I now use, I have been using this for, maybe a good, at least 5 years, I think. The robot to do knee replacements. I love it, and I don't really want to go back to the conventional way, even though that's most of my career has been using the conventional instrumentation for a knee replacement. I've been using the robot, which gives me precise cuts in the bone and allows me to balance the knee more precisely. So I would say that's the most cutting edge technology that I'm using right now. I'm hoping for other biologic technology to be approved, because guess what? We're still replacing joints with metal and plastic components, and we've been doing it for decades and decades. So I'd love at some point if we were able to do biologic treatments or injections to recreate cartilage that's lost in the hip or the knee. And they're working on it. We have studies looking at that, but nothing definitive right now.
That's like regenerative medicine kind of techniques.
Absolutely.
What do you know about that landscape so far? What does it look like?
Well, we're doing bone marrow aspirates, so trying to take some of those healing cells from within the bone and inject them in other areas of the body, such as the knee or the shoulder or the hip. We're using platelet-rich plasma, so that's when we draw blood from the patient, like we're checking a lab, let's say. We take that blood, spin it down in a centrifuge, and take a high concentration of the healing factors from their own blood and inject it into the area of pathology. So we have good evidence that it helps with mild knee arthritis, lateral epicondylitis, which is tennis elbow, and gluteus medius tendinosis. So that's just some degeneration of the tendon around the hip. And then we have other evidence that it helps in for other conditions and is used for other indications. But I'd say those three, we have the best research supporting the use of it. But I'm hopeful that there will be other technology in the future.
Have you seen personally that like PRP works better than a regular like cortisone injection, or like biologics just working better than?
I have cortisone. I will still use cortisone for my injections for certain indications. Platelet-rich plasma is also used. There's some patients, they come in with this preconceived notion that cortisone is bad, and that's not all entirely true. I would say it is very useful for certain conditions. In others, platelet-rich plasma might be a better choice.
Yeah. And even in like trauma care or fracture care, regenerative medicine can be probably huge. Just instead of having this cast over your arm or over your leg for 6 weeks, you just do some injections and it will like fuse together basically.
Yeah, I would say being able to turn on and off healing in the body would be almost the holy grail in orthopedics, at least, because there's a lot of problematic orthopedic injuries or conditions in achieving healing, whether it's a tendon, cartilage injury, fracture, and we're trying to be able to stimulate healing. Some patients can't heal a fracture properly, maybe because some of their medical conditions that are contributing to that failure to heal. And if we can boost their healing with other factors, other procedures, that'll be helpful. And we have those as well. So hopefully there is ongoing research. I stay up on that, but hopefully there's more progress in the near future.
Yeah, and orthopedics, based on my knowledge, is very reliant on the body's ability to heal itself instead of going basically right into surgery. If someone has like a rotator cuff, minor rotator cuff tear, they can try and rehab it instead of going directly to the OR.
Absolutely. I think the body has an amazing ability to heal itself. As I just spoke about, there are some other factors that could be medical problems that attenuate that process, but it can heal very well. And so I would say I'm considered more of a conservative surgeon, where I always try the conservative management in the form of therapy, injections, even acupuncture, because a great number of the patients and great percentage of the patients can get better with just that. I mean, patients don't want to have surgery if they don't have to. So most of the time, you're not burning any bridges by attempting that conservative management. And if it doesn't work and surgery is indicated, you can always do that later. I mean, that's not always the case. If you have an acute fracture, you don't want to sit on it if there's an indication for surgery. But let's say someone has a partial thickness rotator cuff tendon tear, no need to go rush to surgery. You send them to physical therapy, have them use non-steroidal anti-inflammatory medications. They can use modalities as simple as ice and possibly an injection. And a lot of those patients will get better.
Yeah.
And not need surgery.
Yeah, that was going to be my next question, is what's the role of physical therapy and acupuncturists and other conservative treatment like that? But thank you for answering. What I will ask is, what is the role of chiropractic in your practice? Is it something that you recommend often, or is it something that you're kind of sketchy about? What's your
I'm certainly not sketchy about it. I will utilize chiropractic care. It's typically not my first line of treatment. I like to go to physical therapy first, because during physical therapy, you'll use many of the same modalities as a chiropractor would. But for the spine, some patients prefer it. They want to go right to it because they've had experience in the past, and I'm fine with referring them if that was their experience. If they don't get better with physical therapy or acupuncture, that's another treatment option. I don't love, high velocity adjustments like in a cervical spine necessarily, but I'm okay using it.
Yeah, there's a lot of people who have a lot of opinions about chiropractic, so I just wanted to get your take on it.
There are certainly, but yeah, that's I'm not anti-chiropractic. I would say it's just not my first line of treatment.
Yeah. You are in private practice, correct?
Correct.
Do you prefer that over being in a hospital setting?
I do. There are pros and cons to the different practice arrangements. I have several friends that are employed at Kaiser, and they enjoy their job. But when you're employed, you have less control over your schedule, potentially over your the types of treatment that you give, the amount of hours that you're required to work. But in that scenario, you also are not worried about managing your practice. You're not worried about where your next patient's coming from. You don't have to do the marketing, really. You have either the hospital do the marketing, or in this situation, Kaiser do the marketing. They hire the staff that you use in your practice, whether it's a medical assistant or physician assistant. You don't have to be stressed about doing interviews and trying to find someone yourself. Whereas, that is something that I have to do in private practice. But I do have control over my schedule of when I work, what days I work. And I think there's also potential for different areas of revenue. When you're in private practice, you don't have much control over that in an employed hospital-based setting.
Yeah. How much time do you take to manage that private practice that you would probably be seeing patients in if you were employed by a hospital?
Many hours a week, I would say. I purposely have an administrative day, one day during a week. I would say 3 days a month. And that helps me get caught up on maybe signing reports or reviewing records and doing some of those other tasks that are required if you're in private practice, like interviewing, searching for maybe a new hire as a medical assistant or nurse in the operating room. So it's enough time. I take that time off, and I believe it's enough to manage those other administrative tasks of being in private practice.
Yeah. Has the need for those administrative days that you personally take, like, definitely, or not definitely, has it increased, or have you always just needed those days from even the beginning of when you were practicing?
I think it's healthy to take certain time off and not work yourself, you know, 60, 80 hours in a week. We had to do that in residency. And even when I first started residency, I was working over 100 hours a week, and I don't think that's healthy. So I believe, regardless of the administrative obligations in a practice, you should take some time for yourself. My family is very important to me, so I use that time also to be with my family, maybe to drive the kids to school or to their activities, and so it is enough time, I would say, for my administrative duties, but I also use it for mental health as well.
Yeah, that's important, especially for the physician. If you have a physician who's not in the right headspace seeing you, then the patient's care will suffer. So I think that's important for most people in most jobs.
There's a lot of burnout. There can be a burnout rate in any career, but in medicine, there's certainly I don't know what the current percentage is, and it probably varies according to the specialty, but there's a burnout rate, and so I think it's important for physicians to take care of themselves as well, so that doesn't happen.
Yeah. As I said, like the patient comes first, and sometimes in doing that, you have to take time for yourself.
Yes, absolutely.
Yeah.
If you're not healthy, you can't take care of other people, right?
Mm-hmm. Is there some things that you did in the hospital that you cannot do in private practice, or vice versa?
Well, if you're in a hospital and you want to do robotic surgery, as I just mentioned, it's not going to be up to you if they're going to lease or purchase the robot. That's the hospital. Whereas in private practice, you can make that decision. I mean, you have to base it on whether or not it's financially a financially viable option. But if you wanted to, you can make a decision. So there's decision making. There's more freedom, I would say, in private practice in making decisions, whether it's how you treat the patients, how many patients you see, the technology that you use compared to the hospital.
So would you say it's based on like autonomy, the differences versus the kind of procedures that you do?
I think there's more autonomy in private practice. Again, there's also pros in being an employed physician as well. In some ways, there's less stress because you're not managing your practice. You're just focusing all of your time and energy to treating the patient.
What do you think about the drop in private practice? Like, I think over 60% of physicians are employed, and that number, I think, is steadily increasing. What do you think of most physicians becoming employees instead of running their own business or running their own practice?
That very well may be the case where we are all employed in the next decade by some larger entity. But for now, I'm holding out, and I'm going to keep trying to maintain a busy private practice, knowing that there is a possibility in the future that could happen, where I'm being bought out, or I'm going to be employed by a hospital.
Yeah, or like a big group that just has a bunch of clinics. Yeah.
Right.
What was your biggest takeaway from practicing medicine, from your journey to becoming a physician, to your fellowship working with the sports teams?
Um, I would say one of the most important things that I've learned in practice is sitting there and being able to listen to a patient, because a lot of times that's all they're looking for. They want to be heard. They want someone to hear their complaints. And believe it or not, just that can help with their conditions, with their orthopedic conditions. The brain is the mind is very powerful when it comes to how people perceive their pain and their symptoms. And I'll give you an example. There was a study looking at rotator cuff tears, and they randomized patients to physical therapy. If they failed physical therapy, they would go on to surgery. But they asked the patients before they started treatment if they believed that physical therapy would work with their rotator cuff tear. And most of the ones that believed that did not go on to therapy, whereas those that believed that it was not going to work ended up going on to surgery.
Wow.
Yeah, randomized. So that demonstrates the power of psychology in orthopedic conditions.
Wow, that's incredible.
So again, listen to your patients, talk to them, show them that you care. If you do just that, you can help a good portion of the patients that come through the door.
Yeah. I mean, an obstacle to that is just the amount of charting that has to be done, right? If you're in the room with a patient for, like, I guess if you have 15-minute time blocks, if you go over that 15 minutes, you're going to be paying for it later with just staying late and charting endlessly. So do you think that I guess burden has decreased overall quality of patient care, or just the amount of physicians who want to listen but just can't because they have time constraints?
I think it's certainly contributed to job dissatisfaction in some physicians, because what do we want to do? We want to care for the patients. We don't want to have to chart and dictate and sign these reports. We want to just be able to treat them, take care of them, get them better. So yes, that will contribute to some dissatisfaction, I would say, among physicians that, and sometimes those are the ones that want to leave medicine because it's too burdensome to do all of that. And yes, they're working later. They're seeing the patients, but now they have all this paperwork to do. They're going home at 8 o'clock at night when they have families, and that's not ideal.
Yeah, and that's looming in the back of their mind when they're seeing the patient is, oh no, there's so much paperwork I have to do at the end of the day.
Right.
And then that's also detracts from the human interaction of being with the patient.
Absolutely.
Yeah. What do you think of, like, the role of scribes in that, or like new AI scribes that are coming out?
As long as they're tested and they're accurate, I think they would make our lives easier in the office, at least in the clinic. I mean, before AI, or at least before the explosion of AI recently, scribes were being used, and I think that facilitates seeing patients in the office and reduces that administrative work that you have to do either while you're seeing the patients or at the end of the day. So
Yeah, because even if a chart can be done quickly, if you have like 40 or 50 charts, that's going to pile up. And if you have a busy clinic, you're probably going to reach that number by the end of the day.
Yeah.
So, yeah, it's rough out there.
Absolutely.
Yeah.
But I'm hopeful that we can utilize AI. We're looking at using AI for different applications here in the office, and certainly documentation of the visit would be very helpful in reducing our workload and administrative tasks. So I'll be closely following that.
Yeah. What do you think the future of orthopedics or just medicine in general looks like? Is it positive? Is it more negative? Is it somewhere in between?
I think I have a positive outlook on medicine. I think we'll continue to have advances in all different specialties, including orthopedics. I'm not right now. I'm not terribly concerned about AI with displacing us as orthopedic surgeons. There are other specialties where it's probably going to be utilized even more, even though it can be utilized in orthopedics. But in general, I'm optimistic. We're never going to know everything, at least in our lifetime, about disease and treatment, and have the perfect treatments for injuries or diseases. But I think we will constantly be improving and honing our treatment protocols.
Yeah. That's the beauty of being human, of like research, is that it will almost always move forward. I mean, that hasn't always happened, but based on our new guidelines and how we do things now, it seems very likely that progress is assured, no matter how it happens, really.
Yes,
Yeah.
absolutely.
With the rise of PAs, of NPs, and maybe even AI a little bit, there's a lot of people who are hesitant to go to medical school, and even because of just insurance and that those paperwork I was talking about. Do you still think that being a physician and going through all of that training is worth it?
I do. I don't have any regrets. The advice that I would give to anyone that's considering a career in medicine is make sure that you're going into it for the right reasons, and not um, because of income, possibly, or maybe the perception of prestige that might go along with having an MD after your name. Going in for the right reasons, and I think it's to help your fellow human being um, uh, who's ill, injured, and return their function.
Yeah, I've been some of the other interviews I did. They said that the most priceless thing that they've ever gotten from being in medicine is happy patients and satisfied patients. It's not like a paycheck or a promotion or something. It's just the look on people's faces when you make them better.
Yes, absolutely. That's the most rewarding part of what we do.
Yeah. If you had to go through your entire journey from being a pre-med to a med student to a resident to a fellow all over again, would you do it? And if so, what would you change, or if anything?
Well, I wouldn't do it right now at my age, but if I had to go back and do it again, yes, I would. I definitely would. What would I change? I think at this point, the only thing I would change would be where I applied for all of my training and education. I was very limited with my applications. I wanted to stay in a certain geographic area, and I think it'd be wise move to expand that geographic area and apply to areas throughout the country, and not just limit yourself. But yeah, I would do it again, and that's what I would change at this point.
That's a very minor thing to change,
Yeah,
which is good. That means like you're satisfied, which I think is something a lot of people don't expect, I guess is the right word.
yeah. Or they're not experiencing it. I am in my situation, in my practice. I'm satisfied.
Yeah.
So I'm grateful. I'm very grateful for that.
Yeah. What's in store for you personally, do you think, in the future? Just more of this? Not that that's a bad thing, but you know.
More of with regard to what?
Just your life, your
Medicine?
practice. Yeah.
It's more of this. It's more of this, but incorporating newer technologies as we go along and as they become available. So I enjoy adding anything I possibly can to my armamentarium while I treat these patients and hopefully get them much better from where they're at when they first came to see me.
Yeah, like I said, that is the ultimate compensation, is helping somebody out.
Yeah, absolutely.
Yeah, well, thank you so much for your time, doctor. It was great talking to you.
Thank you for inviting me.
Yeah, no problem. So I'll see you around.
All right. Take care.
Bye-bye. Thank you so much for listening. I hope you enjoyed. If you don't mind, please leave a like and subscribe. And with that being said, see you in the next one.